So I'm actually a pediatric endocrinologist, so I take care of the children and adolescents at the Davis Center, and then also do research. And one of the, let's see if this works. I'll just push it out. So one of the areas of research I'm very excited about is the artificial pancreas. And so what I'd like to go over a little bit tonight is, as far as an outline, why do we need this? And I think everybody in this room kind of knows the answer to that, but some groups you have to explain it. What are the different parts of an artificial pancreas? And right now it's a pump, a continuous glucose monitor, which we have, and then a computer or an algorithm to tell them how to function. I'll talk a little bit about some current research and focus on some of the research we're doing at the Barbara Davis Center, and then talk a little bit about the timeline. When do I get my artificial pancreas? Sounds good. When do we get it? And hopefully have some time for discussion. But please interrupt me if you have any questions as I go through. I'm happy to answer. So, why do we need the artificial pancreas? Well, I'll just show you some data here. This is from a study called the Type 1 Diabetes Exchange. Is everyone familiar with that study? It's a study that got founded about 5 years ago, and there so far are over 26,000 patients with Type 1 diabetes who are in this, and it's a registry. Part of it is to describe what's going on with people with type 1 diabetes, but then the next step is to then, after you identify what some of these issues are, do some clinical trials, do some studies, try to test things to see if you can improve upon how we're providing care. What this slide shows is we're not doing as well with A1Cs as we'd like to be, and it doesn't depend, it doesn't matter what age group you're in. We've got people on the Type 1 Diabetes Exchange that are over 65. We've got children 2, 3, 4, 5 years of age. And in each of these groups, because we've got 26,000 patients, there's 4,000 or 5,000 people in each of these groups. And you can see particularly here in the middle ages, the adolescents, the 13 to 18-year-olds are higher. And we all know there's a lot of challenges with adolescents. And a little bit surprising maybe is it's not like you turn 18 and the light bulb goes on and everything gets figured out. So it's really until people get in their mid-20s that we start seeing that there's a reduction in A1C. So another way of looking at this, we looked at it just in the children and the adolescents. And we looked at what percent of the children and adolescents by the different age groups were meeting the goals for A1C. There's a group called ISPAD, and that's in the hatched lines, the hatched bars, that shows what percent of the group made an A1C less than 7.5, and it's only about a quarter of each of these age groups. Now the ADA says that your goal for an A1C should be less than 8.5 if you're 1 to 6, less than 8 if you're 6 to 13, and then less than 7.5 if you're in this 13 to 20-year-old age group. So we've got some work to do to try to improve upon how we're doing right now. This is a slide from a German group that has over 30,000 children and adolescents. It's called the DPV study. And the reason I put this slide in is to show that we are doing better over time. You can see this has the average A1C starting at 95. That was just after the DCCT trial, showing that lower A1Cs led to better outcomes. And so since then, there's been a steady decline in A1Cs. So that's good news. I think that, that's wonderful. But if you look at this, the decline is about 0.04% per year. And so what we'd like to do is have this line coming down a little bit quicker. So we're doing better, but we're not getting there as fast as we'd like to. So another reason that we need improved ways of taking care of people. It's not all just A1Cs, as everyone in this room knows. Hypoglycemia is a big challenge as well. And this just is another paper from the Type 1 Diabetes Exchange, just showing that the rates of severe hypoglycemia, depending on what your A1C is, just looking at it one way, can be between 10 and 15% of having a severe hypoglycemia episode. Yes?
What is A1C?
So A1C, good question. That's a hemoglobin A1C. So it's a test. Our way of explaining it is it's basically measuring how much exposure you've had to sugar, what your average sugar has been over the last 3 months. The way we're able to do that is our red blood cells last for 3 months. There's always new ones coming and old ones dying off. And we all have sugar in our bloodstream. And so if you've got uncontrolled diabetes, you got a lot of sugar attached to your red blood cells. If you've got well-controlled diabetes, then you've got less sugar attached to your red blood cells. And if you don't have diabetes at all, you still have some, but it's even lower. And so that A1C test lets us know how the control's been the last 3 months, but it also lets us know what your risk for problems are in the future. Eye disease, kidney disease, heart disease, nerve disease. So that's why we get so focused on it. Thank you. Please stop me, because doctors are terrible about throwing out these abbreviations and just assuming that everyone knows what they mean. You know, the PhDs are bad at it too. I'm pointing back at Eric, but doctors are awful at throwing out abbreviations like that.
What should it be if you were not diabetic?
Well, it should, if you're non-diabetic, it should be less than 6.5. Yeah, yeah.
Is there an A1C that represents too tight of control?
That's a great question, and you can look at this slide. That's a debate, and it's if there's a debate, that means no one really knows for sure, right?
And would you
Right.
say that in relation to mainly because our son never reveals his A1C except when it was 6.2.
Yeah, and then is that too low? So that's what I think this is interesting, because it shows that if you tried to go too low, you have a little bit more hypoglycemia. Now that's going to be different for each person. It might be different if you're a toddler. It might be different if you're in your 70s. It might be different if you're in your 20s or 30s. So that may be different for everyone. And you got to balance that A1C, not too high, but then not too many low blood sugars. And that's a challenge everybody knows.
And would you have a different parameters if they have a CGM or not?
Good question. I think we're still trying, with this new technology, we're still trying to sort out how do patients use it, how do we help patients use it to make things better. But keep that thought in your mind as we go through the next couple.
Are there any differences in target thresholds for type 1 versus type 2?
I'm take care of kids, and we have fewer children with type 2 diabetes. We still try to aim for less than 7.5 because they're adolescents. Really younger than that, they don't get type 2 diabetes. So, another way of putting it, as low as possible without causing too much hypoglycemia. So, that's kind of a simple way of doing it. So, who's ever seen, this is a continuous glucose monitor tracing, and let me just orient you to it. This has the sensor glucose level. Here's 100, this line is 60. And so what this shows is this person had a blood sugar, and all of a sudden it got low. This represents alarms that were going off. And this person got low, and they slept through those alarms going off. This was a 17-year-old. Back to your question, at a 6.2, okay.
Yeah.
How low is too low? Well, it depends. But certainly this night for this 17-year-old, they slept through those alarms. And if you're low, you don't react quite as well. If you're asleep at night, you don't react quite as well. And so this child had a low blood sugar for almost 4 hours and then had a seizure. Then the blood sugar came up. Now what this part of the slide is showing is how insulin was being delivered. The pump didn't know what was going on because the pump's not connected in this case. This is an old slide. And so the pump just kept pumping the insulin in, right? We'd all like for it to have stopped right here. So keep that in mind. So do we need for many hours? And that can be really dangerous then when you're low for a long time. So that's just one example of how that system can work. I underlined Dr. Garg and Dr. Slover, who are in charge of the adult clinic and the pediatric clinic, because they were part of this study called the Aspire study that tested this threshold-based or low glucose suspend system and showed that it worked really well. And I'll show you a couple of slides on that. It just showed that basically when you compared people who were using the threshold suspend to people who weren't, that there was about a 40% reduction in the amount of low blood sugars that they had. So that was a pretty significant reduction just with this system. And it didn't change their A1C. It didn't cause them to have higher blood sugars either. It just got rid of the lows. And so how that worked is, and this is an average of all the data from the study, but as people got low, the system shut off, and then they came back up, but they didn't go too high. So if we can get rid of those lows, that would be a wonderful thing. And so the good news about this system is it's been approved for about 5 months now, 4 or 5 months in the US. It got approved in 2009, pretty much everywhere else in the world. And my sense from just being at a meeting where some people like Aaron Kowalski with the JDRF who's really pushed this, is that the FDA's really, I think, kind of taking some heat, and that they're trying to really work with researchers and companies to get this moving forward because of people like you and people with the JDRF, other people saying, look, this is silly that you can have this in Canada and Switzerland and Mexico, but you can't have this in the US. And we need to get this system out to patients and people with type 1 diabetes. So that was the first step. Now that second step makes sense. Why wait until you get to 70? If we see your blood glucose is going down, let's stop it earlier. So the goals for that are eliminate the prolonged episodes of low blood sugar, particularly at night, and that's the study I'll show you. And we want this system to kind of work in the background so you're not having to do anything, but these alarms will only go off if you get really high or really low. And then we also, by turning off the insulin, we don't want you to have high blood sugars. We don't want it to cause you to go too high because we turned it off. So what's this system look like? You've got the pump, right, with insulin going in. We've got, for the study, we had 2 devices. This was the continuous glucose monitor sending the data here. And then you have the glucose information going to the computer that had the algorithm to then tell the pump how much insulin to turn off if you started approaching a low. So anybody see problems with this? Well, right? This isn't a commercial product, is it? So one of the projects we're working on, I hope to get started in the next few months, is working with engineers to replace that with something like this, okay? So maybe you carry your cell phone and then you got your artificial pancreas, in your other pocket, and that's in the works. And I think with all of this, everything I'm showing you here, it's going to be studied in pretty small groups. It's not going to get out to the marketplace until it's shown to work in these small kind of hand-selected people, and then all of a sudden it's going to go out into thousands of people, and that's where the industry is going to learn, hey, this, the people are telling us they don't like having to wear 2 things, or the sensor hurts, I'm not going to use it, or the alarms annoyed me, and I took it off. I mean, imagine a 16-year-old in class and something beeping. Okay, so all of these products, you're going to study them, they're going to get out there, and then they're going to have to get made better. But what technology do we have that doesn't go through that same process, right? Yeah, you got to start someplace. So I think we're making progress here. Yeah.
I've got something that I'm putting in the newsletter this week, and it's this girl, I think she has all that, and she's texting her pancreas. So I think I'll send it to you before I ask her.
That's great. So how does this system work that's a little bit different? This predicted low glucose suspend as opposed to the wait till you're low and then suspend the insulin? So the way this works is as this glucose started going down, this is the sugar measured 2 different ways with the dots and the red dots and the blue line. The green is how much insulin was going in, So we work with some really smart engineers who are able to do the math on this. And they've got the algorithm where they said, okay, when it got to here, they said, okay, it's going to go down below 80 in 30 minutes. So we're going to stop giving any insulin. And guess what? It works. Okay? And so instead of this person continuing to go down, it took a little bit of time, but this stopped from getting low. Okay? So that's the advance, turning it off before you get low when we're predicting you're going to go low.
How much work is involved in like customizing that? 'Cause, like for an active 17-year-old, it's you're in a different.
Good question. And let me show you a couple more, and I'll come back to that. So this is data from a study we did with 15 to 45-year-olds, and we didn't see an effect on the 15 to 21-year-olds versus the 21 to 45-year-olds. And what we found was, and the way we did this study was a little bit unusual, novel. We had people would have to start the system up at night, and they didn't know if it was going to be a night where the system was working or not working. And the reason we did that is because we had to show that it worked, it didn't work. Now you could say, well, gosh, it's going to work a lot better if I know it's on every night than if I'm not sure if it's on every night. It might prevent more low sugars. But what it did was it reduced by almost 50% whether you were low for 30 minutes, 60 minutes, then for being low for 2 hours, it reduced that by 75%, and being low for 3 hours, it reduced it by 80%. So it really reduced the amount of time people were below 70, and it did that without increasing high blood sugars as well. So back to your question of now, is this going to work in different age groups? We are now repeating this study. We're almost done with the 11 to 14-year-olds. And this was almost 2,000 nights of people in their home. This wasn't locked up in the hospital. They were at home and had the system. So we're almost done with the 11 to 14-year-olds, and we just finished first 200 nights of the 7 to 10-year-olds. And we just got approval because there's what's called a data safety monitoring board, and they make us stop after 200 nights with each new group. They look over the data and make sure it looks like it's safe. So they just gave us the green light to keep going with all 2,000 nights in the 7 to 10-year-olds. And they also said now we can start with 3 to 6-year-olds. So if you think about, I don't know if anybody has grandkids or kids who were little when they got diagnosed, but boy, I'd love to be able to have this as an option. So this just shows the difference in percent of nights having a glucose less than 60. Whether you were in the control group, they had about 10% over time. And if you had the system turned on, it reduced the amount of low sugars that you had pretty dramatically. Now, one thing that's interesting that I hadn't thought about, but of course it makes sense, is it takes about 2 hours, 3 hours for this system to show a difference. And that's because people had insulin in their body from before the system got turned on. That makes sense, right? If you took a shot of insulin, a bolus of insulin through your pump for bedtime snack, and then turn the system on, the system can't make the insulin go away. It can only stop new insulin from going in. So that argues that, well, maybe we should be doing this 24 hours a day and not just at bedtime, just over nighttime. The reason we studied this first at nighttime is it's easier because you don't have food coming in, you don't have exercise coming in to affect the blood sugars. And also, I think it's when parents, at least, have most fear about the child going low. So that's the second step. Now, the third or fourth step, they're going to be a little bit more challenging because we talked about what happens if your sensor is not reading accurately. What if the sensor says you're 300 and the system says give more insulin, but you're really only 150? Well, that worries me, right? So we got to be a little bit. It's one thing to turn the insulin off and you end up being just a touch higher. It's another thing if the system would cause you. So That's why those are the later steps. So these are all the challenges, the insulin delivery, accurate blood glucose sensor information, the algorithms. If we had a more rapid insulin, that would be great. Food and exercise are really a challenge for all of this. And this just shows they compared doing a closed loop in the hospital, having the sensor talk to the computer, which told the pump how much to give. And the blue day is when they just let the computer do everything. The red day, and these are blood glucoses, you see the red day, it was much lower. And it was lower, particularly after meals. And on the red day, they had you give your insulin before you ate. And so the computer can't catch up unless you tell it you're eating. So that's one of the challenges with food.
Doctor?
Yes.
You keep referring to